Transferring critically ill patients within and between hospitals is common. Unfortunately, training for these transfers is not. This short film documents the transfer process between two hospitals and highlights the key learning points during this process, with particular emphasis on the ambulance transfer itself. It uses the example of a neurosurgical emergency, but the principles apply to all transfers of critically ill and injured patients. There is one useful mantra to consider when performing critical care transfers. Whether it is 100 yards or 100 miles, the same principles should be applied. The most important aspect of these transfers is preparation. Preparation is everything, even when the transfer time is critical. To emphasize the important issues, we will be following Rebecca, a 27-year-old woman who was escorted to an emergency department following a head injury. Rebecca's head injury has turned out to be serious. She had a seizure after she arrived in the emergency department and required intubation for a CT scan. The scan showed an extradural hematoma, which requires urgent evacuation, and she will have to be transferred to another hospital. Current evidence shows that the outcome for this injury is better if she has surgery within 4 hours of the initial injury.
Andy, could you do me a favour? Yeah. We just get some spare drugs drawn up for the transfer.
Monitoring and management should be dictated by the patient's condition, not by the fact that they are going to be transferred. In Rebecca's case, the salient points about neuroprotective management for head-injured patients apply. The tracheal tube should be taped but not tied. Keep the patient well oxygenated. Aim for a low to normal arterial CO2. Use expired CO2 monitoring. Maintain a mean arterial pressure of about 90 millimeters of mercury. Use femoral central venous catheters rather than necklines, as the latter can impair venous return from the head and increase intracranial pressure. Maintain a 30-degree head-up tilt to help reduce intracranial pressure.
Hi Pascal, thanks for coming down.
I gather you need me to go on a transfer.
Yeah, sorry about this. I'm just up in theatre and I got fast bleeped down here to see this young lady.
The doctor and nurse escorting Rebecca are not the same ones who have been looking after her, so a comprehensive handover should take place as early as possible.
About 10 minutes after she came in, she had a grand mal seizure. A&E gave her 4 milligrams of lorazepam.
Okay.
The escorting staff need to be briefed on the relevant history and undertake an ABC review of the patient and transfer equipment to ensure that they are fully aware of the patient's status prior to transfer.
Have we contacted the next of kin by any chance?
No, actually, I've got her number here. Would you mind doing that?
Yeah. Do the drugs first, then I'll give them a call.
Cheers, thanks very much.
No worries.
And remember, well-filled patients travel better.
Rebecca, I'm just going to examine you.
Once it is apparent that a transfer will be taking place, documentation should start. Preferably, this should be in the form of a dedicated transfer form.
Andy, do you mind doing a gas for me, please?
Yeah, of course.
If the patient's condition allows, you may wish to stabilise the patient on the transfer equipment for about 20 to 30 minutes prior to departure. Remember to keep the equipment plugged into the main supply, though.
Shall we now check the transfer bag?
Yeah, good idea. Okay, we've got the bag valve mask kit.
All equipment, including the transfer bag, should be formally checked against a checklist, rather than using the informal manner shown.
Have you done the oxygen calculation?
Yes, I've done that already, and we've got enough oxygen for our trip.
We recommend carrying 150% of the calculated oxygen that will be required.
IV emergency drugs?
Yeah, we've got those, all of those.
Okay, in terms of infusions?
I've got a spare noradrenaline and a spare propofol drawn up and ready to go.
All right, fantastic. So do you want to ring the ambulance?
Yeah, sure. Hello, I have a critical transfer for you.
The ambulance control use specific terms to triage the urgency of their ambulances, and it is imperative that the correct terminology is used, or else a critical transfer could be delayed.
I have a critical transfer patient for you.
At the time of filming, the most urgent request in London is the critical transfer, for which an ambulance should arrive within 15 minutes. This request should be used for time-critical transfers, such as neurosurgical, cardiac, or vascular emergencies. However, it overrides all other calls in the area, even out-of-hospital cardiac arrests, so it must be justified.
Neuro patient.
If special equipment or monitoring is required, this should be communicated to the ambulance control, who will pass the information on to the dispatched crew.
Yes, the patient will be accompanied by an anaesthetist and a nurse, so an EMT crew will be sufficient.
For most critical care transfers, an EMT crew will be adequate. Remember, requesting a paramedic crew will take them away from potentially life-saving duties.
Thank you. Bye. Hiya.
Hi, I'm Pascal. I'm the anaesthetist, and this is Margaret.
Hi.
Our senior nurse will be coming with you on the transfer.
When the ambulance crew arrive, there are a number of important aspects of the transfer that need to be discussed. Communication is everything and should include the exact destination of the transfer. You should state how you wish for the transfer to take place. Steady with minimum accelerating and braking should be the norm. Remember that extremely fast driving puts the transfer team, the patient, and members of the public at risk and can rarely be justified. Will they be able to bring you back? If not, make sure alternative arrangements have been made, for example, a hospital taxi. Remember that taxis can't transport compressed gases unless they are displaying a green compressed gas sticker.
Andy,
Yeah.
do you mind calling Charing Cross Hospital to say we'll be leaving shortly?
Yeah.
Great, thank you.
When transferring the patient onto the ambulance trolley, establish which side will be secured against the wall, and then package the monitoring and equipment on the trolley so that access will be maintained at all times throughout the transfer. And finally, perform a last-minute check to make sure that you have everything, including notes, blood results, x-rays, and scans.
Okay, hold on a second, I just need to get the ventilator. Okay. Margaret, are you okay to come up once we've got the patient on and settled?
Okay.
All right.
There are a number of issues to consider regarding the ambulance itself. You have the same indemnity and insurance in the ambulance as you would in your own hospital, assuming you maintain the same professional standards of conduct. Try to be seated such that you can monitor and access the patient's airway and equipment without the need to remove your seatbelt. Make sure that you secure the patient and equipment thoroughly.
Okay, let's get this oxygen sorted.
Familiarise yourself with the location of the suction unit, oxygen cylinders, and the defibrillator.
Spare in the cupboard. We've got.
Ask whether or not it is possible to run your transfer equipment's power from the ambulance using an inverter.
If you could both put your seatbelts on.
Check what you should do if you need to remove your seatbelt or deal with a patient problem.
Excellent. Right. Okay. All ready to go.
Appropriate conduct in the back of the ambulance is essential, and good communication with the ambulance crew should be maintained at all times. If you require the use of the ambulance equipment, it is the ambulance crew that should operate it.
Oh, Margaret, I don't think I'm feeling very well.
Vehicle movement can have profound physiological effects on the patient and on escorting staff.
What's that alarm?
It's the NORAD. Sorry, it says pump failure here.
Do you need to
Sort
get
of-
up?
Yeah, I do. Sorry.
Claire, we're just standing in the back. If you could just take it steady.
Okay.
Incidents during transfers are common and may require the escorting staff to remove their seatbelts in order to access the patient or equipment.
MAP's fine.
In such a situation, they should communicate with the ambulance crew first. The driver may either decide to continue in the knowledge that the passengers are not belted, or they may choose to stop. This will depend on the difficulty of the procedure being performed and the urgency of the transfer.
We're okay now, Claire, thanks.
Okay.
Remember, any incidents that take place during the transfer should be recorded and submitted for appropriate governance review at your base hospital. It's easy to be minimalist with equipment that you take with the patient on the final leg of the journey. Don't be. Many a transfer has gone horribly wrong during the last leg.
Oh, hello. Is this the lady with the extradural? Yes. You got here quickly.
Hi.
Hi.
I'm Pascal, the anaesthetist.
When you finally arrive at your destination, it is easy to collapse in a heap and do a dump and run. It is worth remembering that the patient remains your responsibility until they have been formally handed over and accepted by the receiving team.
So this is Rebecca. She's 27 years old.
A comprehensive handover is crucial, and it is worth compartmentalising it so that you don't forget anything.
She's currently sedated.
For example, discuss the presenting history, examination and investigations.
She came to our emergency department. Her GCS initially was 15. However, she subsequently had a fit.
The events and management at the referring hospital.
She's sedated with some propofol and some noradrenaline to maintain MAPS greater than 90.
The transfer.
She's been absolutely stable during the transfer. However, one of our pumps did fail, but we managed to sort it because we had an extra pump.
Any changes that have occurred since the initial referral.
Fine. When did you last look at the pupils?
About 10 minutes ago, and they were equal and reactive.
When all this is done and the receiving team are happy, you are free to return to your base hospital where your valuable work can continue.
Just give us a hand to get her over onto the bed.
Your last challenge may well be how to get there and to return with the same equipment that you left with.